My main interest as a researcher is to try to understand, using data, the ways to improve healthcare. In order to do that, specifically within this theme, we're interested in finding out, for example, how conditions arise, how they are diagnosed, how they are also managed, and finally, what are the prognosis for these different types of conditions. We do that by using different types of data. This data can arise from either already collected information or from other sources. And what we intend to do is somehow find out what are the associations between patients' characteristics and also the resources that are available, the treatments that they will get, and finally what will happen to them in the long term. We have collected a lot of information already in different types of cohorts. Cohorts, what they mean is a study based on a group of participants identified for a particular characteristic. It could be, for example, people that have had a myocardial infarction, a heart attack, for example, and we follow them up. We identify them earlier on, and we follow them up for a few years, let's say, to find out what's going to happen to those individuals. That's a typical cohort study. And within the BRC, we have several of them based around people that have had a stroke, for example, people that have had valvular disease, which is a problem in the heart, people that have had some kind of kidney impairment. And what we're interested in finding out is if any of these group of individuals are more prone or less prone to having what we would have imagined be other important events, such as an increase in the risk of death, or an increase in the chances of them having other kinds of conditions inclusive. Now, within the theme, we also, besides the cohorts of data we already collected, we use electronic health records. That is, data that have been collected for usually other reasons, typically administrative reasons. Could be in general practice, could be in hospital. For example, people that go to hospital and they come out of hospital, we have a record of those. And we can use that information to also ask important questions about the associations between, let's say, if someone at a particular age is more prone or less prone to having one of these type of events, let's say a heart attack, for example. So we normally, in this theme, or at least in the area that I'm working in, we don't collect new data. We reuse the data. We do what we call secondary analysis of the data. And we think that it's more appropriate because the data has already been collected. It's cheaper in many ways to actually go and collect the data. But that also carries some disadvantages in the form that obviously the data were not collected for the research question or thinking of that particular research question in particular. And there might be some biases that we need to deal with, and that's where the methods in a way come in. One thing that we've been working on in the last 5 years or so is trying to understand how kidney disease, or chronic kidney disease in particular, is managed, is dealt with by GPs. We've identified that very often people that have this condition do not know about the condition. At the same time, we know that kidney impairment or kidney function deteriorates with age. So what we're trying to do now is to use alternative ways of communicating when someone's kidney is not working as well by using the term kidney age. And by using kidney age, if someone is 70 and has a kidney age of 70, that's straightforward, even though the kidney is actually not working as well as someone from 50, age 50. But if someone is 90 and has a kidney age of 70, then it's probably doing fine.